So I've just done the welcome. So Professor George Mellotte will be going through the introduction to home dialysis, and he's a very good slide presentation. And then we have three patients who are going to tell their stories about their experiences of the different types of home dialysis. So delighted with that. And then we'll have a session, as Colin has said, to answer questions. Now, the one thing I would stress is that we cannot answer individual clinical questions. We can only answer general questions, and that's simply because this isn't the appropriate place to do it, because we don't have all the information to answer that. So if you can keep your questions to general questions rather than this is my situation, this is what my nephrologist has said to me, because we really can't expect George to answer those. And then after the questions and answers, there's been some good developments on the vaccinations. So Colin White is going to give an update on that, and that'll be quite quick. And then we'll have a future events update just to share with you some of the other items that are happening. And we're going to do a very quick Zoom poll. We're getting some reports that people on dialysis are experiencing problems with skin itching. So we just wanted to do a quick Zoom poll on, is this a problem for you? And then we're looking to get feedback on the meeting. Did you find it useful? And feel free, it's all anonymous, so you can be totally honest with us as to whether you found the session useful. So we're hoping to finish up about 8:15, so it won't be too long. Okay, so at this stage then I'm going to stop sharing, and hopefully we'll get the technology to work, and we're going to hand over to Professor Mellotte. And thank you very much again for being here today, Professor.
Good evening, all. Thank you, Carol. Thank you, Colin, for inviting me to give this talk. Usually, the start of these lectures, you always declare conflict of interest, and I'm going to declare a conflict of interest in that I'm an advocate for self-dialysis. I think most doctors who ever had to be in the same situation as many of our patients are, that they need dialysis, would choose to do dialysis at home. So I'm going to start off. I'm not going to go to the technical difficulties or technical issues, how to do dialysis. Just an overview of how we see it, what it's involved, what are the advantages, what are the disadvantages, and just a general walkthrough. So if I get my first slide, please. I'm a consultant for more years than I like to remember. 25 years ago, I did one of the first surveys on the prevalence of dialysis in Ireland. And at that stage, there was 641 people on dialysis. 491 were on hemodialysis, and 150 were on peritoneal dialysis. Over the last 25 years, we've seen an almost fourfold increase in hemodialysis, but the number on home therapies hasn't even doubled. And I think some of that was, if you build it, they will come. When I came first back to Ireland, the dialysis units were far, far apart, and people had to travel a long distance for dialysis, so they had no choice except to go on home therapies. Now, with more dialysis units, it's easier to go to the dialysis centre. COVID has influenced things. On average, we saw 2 new patients a year starting on home dialysis, maybe 4 or 5 on home hemodialysis. But in the last 2 years, there's been a significant growth in the number of patients on home therapies. And we will go into some of the reasons for that. It's not unique to Ireland. When I talk to my colleagues all over the world, I was at a virtual meeting in Norway on Thursday night and talking to Peter Blake from Canada, and they saw the same increase in people who wanted to do home-based therapies rather than going to a dialysis unit. Some of that is driven by the fact that transplantation worldwide has dropped significantly and hasn't still recovered. But I think it will recover, and we are seeing green shoots of recovery everywhere in the health service. Next slide, please. One of the questions is, when do I start dialysis? We used to have a syndrome of symptoms we used to call uremia, where you had sick, nauseated, itching, losing weight because you're feeling so sick. That was an indication to start dialysis. if your kidney function was less than 8% GFR, less than 8, a creatinine of 500 or 600, or you're getting problems with your nutrition, or you're getting very high potassium levels. But increasingly, we're now starting dialysis earlier, before symptoms become severe. And it's a concept that's now getting well established called the incremental start, where you start with a low dialysis dose and you build up your time on dialysis as you need it. Next slide, please. So people are offered two choices. They can do self-care, look after themselves, and they can do center care. And I sometimes put this to the difference between going to a self-catering apartment or going to a hotel. Next slide, please. Could I have my next slide? Okay. First, what dialysis option should I go for? There's a lot of studies out there, and some will show slight differences, but I think a lot of it is due to, the bias of the authors, where you're doing your dialysis, who's involved with it. One thing you got to remember: the people who choose to carry out their own self-dialysis tend to be more compliant with treatment. They tend to be stronger and medically less complicated. So that's something you've got to take in mind when you read this. We've also got bias in certain countries. There's a financial incentive to do one type of dialysis over another. It doesn't happen in Ireland, but it does happen in other countries. In my view, the choice of treatment is completely and utterly patient-driven, and it is possible to change dialysis modality as circumstances change. That's an important issue. Just because you pick one doesn't mean you're stuck with it. And we often see people who are on in-center dialysis for a long time switching to home, and we see people on home for a long time switching to in-center. Next slide, please. So let's go and see what the center-based dialysis. I often think we give people a very rosy picture of what it looks like. So just press the button there and just, enjoy our luxury hotel dialysis service. A limousine will come and collect you. Machine will be set up and waiting for you on your arrival. You will be met by a highly professional nurse who will carry out your dialysis. Light refreshments will be served during your treatment session. A specialized doctor will be available on request. Next slide. Sorry, keep going. There's a few more things on that, Colin. Just press the space bar.
Sorry, it keeps locking on me every now and then.
Okay.
One of the joys of technology.
Yeah. Well, it'll tell me to speak slowly, and the limousine will take you home, and it's all free of charge, and this all sounds fantastic. However, if you go on to that one called TripAdvisor, but tripdialyzer.com, next slide, you might hear the real truth. A lot of people will describe the transport as being slow and unreliable. Taxis not turning up on time. You will come when we say you will come. You'll leave when the taxi turns up. And sometimes not now at the moment because of COVID-19, but I suspect that will change over the next few months. You will be sharing taxis once again, and that will add to the time. For scheduling issues, people will be brought in early, and you might find your machines not ready when you come in, so that has to be cleaned, disinfected before you can get on. And then you're watched for a while afterwards, and the taxi will finally arrive after it drops somebody else off, and you come. So it's not very flexible. And as we've all seen, many patients in the unit are sick. Sometimes it's because you keep your sicker patients in the centre. There's an increased infection risk. Now, Ireland has done remarkably well compared to the rest of the world. We're one of the few countries where the number of people surviving on dialysis actually increased. There was severe adverse events in other countries. And it's frightening. It's got to be frightening, seeing all the sick people. Next slide, please. When we talk about home-based therapy, and the patient gets frightened because the patient has to do all the work. He has to set up the machine. She has to clean it afterwards. store the supplies, arrange delivery, make sure someone is there. It sounds daunting. And all the medical support is in the hospital and you might need to have backup. But again, COVID has shown us we can do different things, how we can deliver care. A lot more telemedicine, a lot more delivery in the spot. And we now putting into place in some centres outreach services. And I'm committed to try and put more outreach services from the NRO into the units to try and improve this. Next slide, please. And people who do home-based therapy are generally very enthusiastic about it. There's no traveling time. We all dialed in tonight with no problem. That's how dialysis can be delivered. It's a time that suits the patient. You can tailor it to your day. Much more lower infection risk. Patients can feel better and eat better, especially if they increase their dialysis time. And I'll talk a little bit about that. The program is small and care is very much individualized. Next slide, please. So what makes people choose home therapy? Well, this slide here was drawn by a dialysis patient. And he has a selection, and you've probably all seen them. Santa Claus, I don't care what day it is. 4 hours is 4 hours. So your home circumstances, it might not suit you to dialysis at home, or it might suit you. You may have support service, you may not have. You may be living in Dublin 24, or you may be living, somewhere west of Clifton. You may be busy doing work, you may have lots of free time on your own. You might like the social aspect of dialysis. There may be medical factors. If you have surgery and lots of scars, you might not be able to do home PD. You may have good veins, or you may have bad veins. And if your kidney is doing some work, you may choose to go for a therapy that preserves your own kidney doing an extra bit of work. Next slide. So, peritoneal dialysis is a home-based self-care system. It's got a dialysis catheter which is in your tummy, stuck in what's called the peritoneal cavity, sometimes known as the Tenchkov catheter, after the man who invented the first version of this. Sterile dialysis fluid is supplied to you in either 2-litre bags or 5-litre bags, depending on what type of dialysis you're on. You need an area for exchange to do the PD at home, and you either have a small pumping device, an APD machine, which is the size of an old video recorder, or a heating plate if you're doing what's called CAPD. For CAPD, you do it 3 to 4 times daily. And APD, or automated or cycler PD, you use a machine, an APD cycler, and sometimes that may be combined with a daytime exchange, or you may leave fluid in during the day. Next slide. So I'm not going to go into what's involved or how it looks like or what it sees, because your dialysis nurse will show you that in great detail. And I have 2 slides. I have 1 or 2 sites at the end that are very good, in particular Kidney Patient Guide in the UK, which has very good cartoons that simply describe this in a lot better detail and a lot more time than I could do it in. So the PD catheter is put in if you're doing peritoneal dialysis about 2 to 4 weeks before you start usually. The reason we put it in 2 to 4 weeks beforehand is there's less likely it's going to leak PD fluid into your tummy or around the exit site if you wait the 2 weeks. The catheter is usually inserted by a surgeon or by your kidney specialist, the nephrologist, depending on which unit you're in. We generally start doing PD using the manual exchanges. There's a reason for that. It's less, sometimes if you use the machine in the very beginning, you may get a small bit of pain on drainage. It's less likely to happen if you use manual exchanges. We use small volume exchanges in our own unit, maybe half a litre in, half a litre out, and slowly build up. We usually try and do the training 50% in the hospital and 50% at home until you get good at it. After a while, when you're good at it, we might try and see, are you suitable for doing the machine at night? That's decided not on how good you are or how bad you are or what you look like. It's based on how the lining around your tummy works. You do a special test called a peritoneal equilibrium test, and that measures the efficiency of your peritoneal cavity. Some people are fast transporters, which allows you to transfer fluid very quickly, and therefore the machine is very good. Some are slow transporters, which allows slow transfer of fluids, but it's not very good for the machine. So we can't use it in people who are slow transporters. Next slide. There's a picture of the machine with somebody beside their bedside and the bags of fluid attached to it. In that one, the machine is done at night. The machine controls the timing and the frequency of the exchanges. You connect up to that machine going to bed at night. You disconnect in the morning. The training might sound daunting. Well, how am I going to connect up all this? How am I going to stick the needles in? How will I know if I do it right? And I sometimes say to my patients, well, can you drive a car? And they say, of course I can. Can you explain how you do it? Well, you hop in the car and you turn on the ignition and away you go. If you think back, what it was like in the beginning, how do you put the foot on the clutch, the foot on the accelerator and change the brakes and get the car into gear? It sounds very daunting. But once you're doing it for a while, you don't even think about it. There's only 2 buttons on it, which of course, are red and green for Mayo, but stop and start. We also have nowadays, it's connected through the internet to share source. So it monitors it, and if there's problems, it can feed back to the unit and tell the people what's going on, and in certain cases, offer solutions remotely, change the prescriptions remotely. So it makes life a little bit easier. Next slide. So I said CAPD is manual exchanges. So a person connects up to the catheter using what's called a 2-bag system. You drain out the used PD fluid, you drain in fresh PD fluid, and you disconnect and you go about your business. We train you how to do that. You do it maybe 3, sometimes 4 times a day, spaced out, either 8 hours if you're doing it 3 times, 6 hours if you're doing it 4 times a day around your schedule. It doesn't have to be exactly 6, it doesn't have to be exactly 8. So there's a bit of flexibility in it. If you're someone who's restless at night, feel you have to get up, or you have children, or you're something you want to do at night, or it might suit certain people how to do it. Increasingly, particularly with the machine at night, there's increment PD, which what I mean by that is you do the CAPD not 7 days a week, or the APD 7 days a week, but you do 6 days a week and have a night off on a Saturday night, which means you can go off and maybe go out, meet friends. When the pubs were open, you could go down and meet someone down in the pub, or go for a meal out in a restaurant without feeling like Cinderella that you have to leave before midnight or anything like that. I think it's important for that, because there's 2 people often with this. There's the carer. The dry day means you don't have to lug around the fluid during the day. So it helps. We talk a lot about infections, but in truth, infections are relatively rare and usually not too serious. And if we ever look at this, and we do the whole time in audit, we find that sort of 80% of the infections are in about 10% of the patients. Some people are just serial offenders and do not follow the program, and the majority of the patients go 2, 3, sometimes even 4 years without infections. Next slide. One of the big advantages of a PD, it's very easy to organize holidays. The machine itself has its own special travel case. And much to Ryanair's disgust, they can't charge you for it. As one of my patients told me very, very carefully, under EU law, they have to travel and they have to mind it very carefully. If you're doing it in Ireland, you put supplies in your car and away you go. If you're traveling abroad and I have to put a plug in for the Baxter Travel Club, they're actually very efficient as long as you give them sufficient notice and you're not going to some place that Baxter don't work in. Sometimes you might need some special training because the supplies in a different country are slightly different than your own country. So that needs a little bit of foresight and planning. But at least you can travel abroad. Nick, just tap there. Again, this is again from Dan, I think his name was Quayle, who's from the Kinks, but he drew this. I sympathise with you, sir, but as in-centre hemodialysis cannot be viewed as carry-on luggage. Next slide. Home hemodialysis is really delivering the hospital-based system in your home. And in actual fact, when you read the original history of hemodialysis, it was how most people did hemodialysis. The idea of bringing all your sick patients into one room and hemodialysis only came in the mid to late 70s. Before that, there were so few people on hemodialysis that they all were mainly doing it at home. There's key components. You need a water treatment unit known as an RO to convert ordinary water to ultra pure dialysis quality water. That machine will reject about 80% of the water coming into it to produce a 20% ultra pure water. The machine itself has two functions. It mixes the water with salts to produce your dialysis fluid, and then it pumps blood from the patient through the dialyzer, the artificial kidney, and back to the patient. And the dialyzer is a device that has a very thin membrane that allows it to remove toxins and fluid from the blood. You need vascular access, i.e. a way to get the blood from the patient into the machine and back again. It has to be able to take large flows of blood. So we either use a central venous catheter, you might hear the term perm cath, or we use a fistula. Next slide. Now, the fistula is done by what you have your vein and your artery, and you stitch the the surgeon stitches the artery to the vein, and the idea of that is to make the vein thick-walled so that it can withstand repeated needling. If you read the original textbooks in the beginning, they used to stick a needle into the artery and a needle into the vein, but that didn't last very long, and they both became thrombosed, and you ran out of vascular access. But then in the late 1970, they invented this operation where you stitch the two together and the vein becomes thick-walled. It takes about 6 weeks minimum, usually about 3 months, for the vein to become thick-walled enough to withstand repeated needling. And sometimes this doesn't work down here in the forearm, and you have to use the bigger veins of the upper arm to get the veins big enough for repeated needling. So we, in most cases in Ireland, about 60%, 70% use an AV fistula. About 20 to 30% of people on home therapies are using a perm cath, which is a double lumen catheter which goes through the skin, tunneled underneath the skin, and it goes into the internal jugular vein with the tip down here in the right atrium, and that way you can get blood to and from the patient. We tend not to like them because these tend to get blocked or infected, but sometimes you've no choice but to use these. So this has a much lower risk of infection. Next slide, please. As you know, in a hospital, or maybe you don't know, a hemodialysis session is typically about 3 to 4 hours. And apologize for this, for the spelling mistake there. And with a treatment time as a period before and after for assessment and the wait, at least 1 additional hour, sometimes longer, and that's independent of traveling time. It's provided 3 times a week at fixed times and not necessarily at the nearest unit to your own home. I put this down, it's not the treatment of choice of doctors, nurses for themselves. There's a survey done of Dutch doctors and Dutch nurses. And whereas 85% of patients in Holland were on in-centre treatment, the doctors themselves, if they were on dialysis, I think it was 70% said they would do home therapy, and only 30% said they do in-center therapy. Next slide. Now the machine can be daunting. I know there's a newer machine now, the AK, which is a bit more compact than that. So what happens is most people who want to go on home hemodialysis will do it in-center for a few weeks to a few months before they decide, well, I can take this on and do home HD. It takes about 4 to 6 weeks to train and to do home hemodialysis. The training is done in the hospital. I do believe if you're thinking about it, there's a role for self-care training in the main dialysis unit, which will shorten your hemodialysis training, like learning to put in your own needles and all that, because that means you can concentrate on how you set up this machine. You do need some support at home. Next slide. Baxter have the current contract for home hemodialysis, and they will install the hemodialysis station in the house, and they'll remove and restore the room when it's no longer required. That's all included in the price that the HSE will pay to Baxter. You will need clean water on tap, and that may need in rural areas testing of the local water supply. You need a plumbing system for draining away the wastewater and space for the machine and chair. You also need some space to store the supplies, which include the dialysis fluid, the needles, and the cleaning products. Next slide. One thing that's quite different about home hemodialysis is that patients have some flexibility, and some will opt to do more frequent dialysis, maybe shorter, or do it for longer periods, particularly at night. So as I said, the standard treatment is 3 times a week for maybe 3 to 4 hours. Some people do short, frequent dialysis 5 times a week for 2.5 hours. Some do, but I think it's about 25-30% do nocturnal or extended, which can last up to 8 hours, and they do it at night. When they do the extra time, most of them feel better. They have less fluid, less side effects, because the gradual fluid restriction means there's less cramps. You can remove a lot more fluid, which means you can eat and drink better. And some patients, particularly those in nocturnal, have no dietary restrictions, and they eat whatever they want to eat, and some of them love it for that. Sometimes we have to tell them to eat phosphate, which for those of you who are taking phosphate binders sounds like an oxymoron, and tell them you must eat more bananas or you must eat more chocolate. But that's how efficient it is. Indeed, Professor Wall was telling me when she was in Canada, when there were some women volunteer, they wanted to get pregnant, they didn't want to be taking drugs, so they stayed on home hemodialysis, and they were getting a lot of extra dialysis, and she was feeding them cola, Diet Coca-Cola, to get extra phosphate into them, to keep their phosphate levels up. And if those of you know Professor Walls, I think she developed a taste for Diet Coke herself as a result of her experience. Next slide, please. What is exciting about home hemodialysis is that there is a lot of interest, particularly in America, because of some changes in funding there, that they're looking at newer, more compact machines that will make home hemodialysis a lot easier to do, even make it portable. And technology, I think, is going to revolutionize how we look at home dialysis therapies. This machine here is the Quanta SC, and it has a sort of cassette that you slide in there, so there's less plumbing to do for the patient. It just has a sort of an in and an out port, and it does a lot of the work for the patient. And they're in trials now, and they're beginning to use them in the States. This particular thingy here actually comes in a small suitcase, and it's got a resorbent, and it's a Swiss prototype that they're looking to launch. And this is a company that Fresenius have bought, FMC have bought recently, that it's a big box that makes the dialysis fluid in batches and it lasts for a week and you use it for routine dialysis. The problem about it is it's not quite as efficient as standard dialysis, but I'm sure it's only a matter of time. And when they want to travel, they use what looks like CAPD bag fluids. So it's an exciting time. And I think over the next few years, we're going to see new hemodialysis technology coming in, and that may make this a lot more attractive to a lot more people. Next slide, please. I hope I'm not going too fast. I sometimes get excited when I'm talking about hemodialysis and peritoneal dialysis in the home. Being honest about it, a home-first approach needs pre-dialysis education and pre-dialysis pathway. When people get onto in-center dialysis, it becomes very comfortable. And people will often say, oh, I prefer the devil I know rather than the devil I don't know. Yes, when they swap over and decide to do home therapies, they're wondering why were they spending so much of their time going in and out of the dialysis unit. We need to organize care and coordinate care, and we need to have people to do the home dialysis training. I keep on telling the HSE that, you know, if you want to use nurses efficiently, you get a lot bigger bang for your buck if you put your dialysis nurse into home dialysis therapy. She can look after a lot more patients than a dialysis nurse in a dialysis center. So hopefully you keep on beating the drum, that message will get across. Next slide. There are barriers to implementation. As I said, support for pre-dialysis care and patient education is not as good as it should be. I'd call it poor, being honest about it. The staffing ratios in home therapies are much lower than in centre. And there's no prescribed standards of staffing. Now, I'll be honest, I got on this job 2 years ago and something happened in the first 2 years that kind of put a kibosh into some of my plans called COVID, but we are addressing this. We're looking and trying to put in additional nursing supporter. I object to and I want to change this. There's no financial incentive to the hospital to do home therapies. There's no penalty to the hospital if they don't do it. In actual fact, it's almost counterintuitive for some of the hospitals. They're better off having in-center activity rather than home-based therapy. There's no reward for the patient doing the work. They're not reimbursed adequately enough. And there's no support structures for the carers. I mean, I do believe that, you know, the IKA do a great job here, but the carers themselves need a peer support work. They're, you know, who they got, and I do think this is something I would partner with the IKA to look at carer and patient need support for home therapies. Next slide, please. There's physical constraints against home therapy. Many patients, particularly patients living in urban areas, do not have the space to accommodate the requirements of home therapy. I mean, if you're living in a small urban house or an apartment in Dublin, you don't have the space, or in Galway or in Cork, compared to, say, living in a large house out in County Mayo or something like that. Some patients don't have the strengths or skills to carry out the home therapies, but love to do it if there's someone to give them a hand, give them some help. Some people don't have a support network. I think we need to look at how we do this. Could we look at self-care or self-dialysis in a healthcare setting? This has been pioneered in Canada, where sometimes they're in nursing homes, sometimes they're in primary care centres. There's 2 machines out the back being used by patients, and they come in and they kind of buddy with each other and support each other. I think we should revisit assisted peritoneal dialysis. See, can we get an assisted peritoneal dialysis program up and running? Can we expand nocturnal home hemodialysis and look at the new emerging hemodialysis technology? It's a lot more smart technology and might not have the daunting wires and tubes and everything that's involved in home hemodialysis at the present time. Next slide, please. I'm also aware that sometimes we look at a problem differently than patients do. We look at Humpty Dumpty and we worry about his cholesterol. And Humpty Dumpty is worrying about the cracks. And we have two different visions of what's actually ailing us. I put up these two websites that I found very useful. There is a one called My Kidney Journey, which is done by Baxter for Ireland. But when I was doing this slide, it wasn't operational. It's back up operational again. I found kidneycampus.ca. It's a Canadian website, but I found it very useful, full of good information. The kidneypatientguide.org.uk, I think, is one of the best websites I know for explaining things nicely and simply. It's all cartoons. I say it was written about 10 or 15 years ago, but no one has changed it. I've been using it for lectures for 10, 15 years, and they haven't changed the content, but they don't need to. It's very simple. Can I have my next slide? We're nearly there. Keep going, yeah. Can you fix the cracks? So to summarize, home hemodialysis. What are the advantages? Efficient clearance of toxins, more control over when you do your dialysis, allows more flexibility in your diet and in your fluid intake, particularly if done for longer and more frequent. Potentially more dialysis is equal to better outcome. There is some evidence to suggest that the more dialysis you do, you might be slightly better. You don't have to travel to a clinic and you have days off without treatment. The disadvantages, you have to have some sort of permanent access, be that an AV fistula or a perm cath. There's a chance of infection. If you're doing a fistula, you have to put 2 needles into yourself at each treatment. Training takes a number of weeks. You need storage space. You need to convert space in your house permanently for a chair, the machine, and the HT machine. Next slide. Peritoneal dialysis. It's flexible. You can fit your treatment around your lifestyle. It's portable, particularly handy for holidays. It's continuous, so it's gentler and more like your natural kidney function. There's some evidence that it will preserve your own kidneys function for a bit longer than hemodialysis. So it gives you a little bit of your own kidney doing a little bit more work. Obviously, there's fewer visits to the dialysis units for treatment compared to in-center. There's no needles. That's why I'd be a wimp. I'd go for this one. I wouldn't like to have to stick needles in myself twice a week. 300, that's 312 needles a year. Thanks, but no thanks if I can get away with it. And you can do dialysis therapy while you're sleeping. As I said, you may be able to get done 6 days a week, but you have to consider at some stage you might have to do it 7 days a week. You have a permanent catheter stuck in your tummy. You have a chance for infection. Because you're carrying fluid, your waistline may look a lot larger. I remember putting a tube in one patient, and she said, "Can I wear hipsters with this?" And I didn't know what a hipster was. Never mind knowing whether you could wear it or not. She educated me very, very quickly. You do need storage space in your house, not as much as you would for home hemodialysis, but you do need some storage space. And it can fail. And in both home therapies, you can have what they call burnout. You can get tired of doing this. It's natural. We're all human, and we're all there to support you. I hope I haven't run through that too fast, but I was given a short brief to get this done in 30 minutes, 40 minutes. I'm willing, I don't know, Carl, whether I'm taking questions now or later, and we'll see how we go.
If it's okay with you, George, maybe we could hear the stories from the 3 patients.
Lovely.
We're giving each of them 5 minutes, if we can keep to 5 minutes, because we're aiming to finish by just after 8:15. So each of these patients is using home dialysis. Michelle, who's first on, is using home hemodialysis. Mary Stewart is using CAPD, and Michael Stapleton, who last but not least will talk about the automated PD. So Mary, if I could hand over to you, and bear in mind, Michelle is going first. Michelle, if I can hand over to you, and bear in mind that Michelle is this one of our first times doing it, and she's a patient just like many of you here. So go easy on her. So Michelle, you have 5 minutes to tell your story.
Great, thanks very much, Carol. My name is Michelle Horn, and I live down in Athy in County Kildare. I've been on dialysis now, this time for about 8 years. I had 2 transplants before. One lasted 3 years, and the second one then lasted 20 years. I had a son with that one, so my little miracle, which is great. This time when I started dialysis, Professor Conlon asked if I would do home dialysis. I said no straight away. I just thought machines, I wouldn't have a clue how to work one. I am very bad at computers. So in a few months I was still on it. He asked me again, would I like to do home dialysis? I said, even just go and talk to the nurses and find out. So I went up to the home dialysis team, and they were absolutely fantastic. And they made it sound like it would be quite easy to do. So they convinced me that I would be well able to do it. So I started training. At this time, actually 8 years ago, and it took about 6 weeks. And they came down, I went up for dialysis in Beaumont, and I did the training up there. And then while I was training for the 6 weeks, Baxter came down and they sorted out the dialysis machine, and they connected me up to the water and the sewage supply. They actually gave me a separate electricity supply, so it wouldn't be connected to the normal supply of the house. So if the house tripped, that would still be okay. So then after my 6 weeks, one of the nurses came down with me for 3 days, just to make sure that I could do dialysis at home. So that was actually quite good in that sense. The nurses come out every so often, and they just check up and make sure that you're doing okay and everything is working fine and everything like that. It is so much easier than having to drive to Beaumont Hospital, because it takes about an hour and a half. But when I was going up the last time, I had to go up with another person. So it took about an hour and a half by the time we went and collected him and came back again. And then, so there's no travel, which is great, especially now with COVID. I was delighted that I didn't have to travel up to Beaumont. As well as that, you're in your own home, so it's much more comfortable for you to be doing dialysis by yourself. I usually do it by myself up in the room. Now, I did get a chair, which was great, but I found that it wasn't as comfortable as lying in the bed, and I had to do dialysis in the bedroom. So I just pulled the bed over towards the machine, and so much handier, just lie in bed. It's much handier, it's much more comfortable. And if you have any problem, because I was afraid at the very beginning that I wouldn't know what to do, and I'm sure I made loads of mistakes, and I'd ring up and it was something silly that I should have known. But when you start out at the beginning, you actually don't realize that you get upset and afraid about something that you don't need to worry about at all. And the mistakes that I made were very simple, and they'd set you straight. And then if there was a problem with the machine, the technicians are at the other end of the phone, and if it was a problem they couldn't solve over the phone, they'd arrive over to you and they'd fix it, no problem. They come out every month as well, and they change your water, or they check your water samples and just make sure the machine is running properly and stuff like that. They're the good things about dialysis. There are a few things now that home dialysis, the electricity, as Professor was saying there, that it's we don't get paid. We get the tax off the electricity. But when you're running the machine, I'm on it for 4 hours every second day. So that's by the time you set up the machine and you put it into a clean at the end, it takes about 5.5 hours. So that's 5.5 hours of electricity every second day. And if you do nocturnal, it would add up to about 9.5 hours of electricity every second day. And that's a lot to pay in that. The machine itself is actually quite a big machine. It lies on a double shower tray. Now you get an RO, as Prof was saying, that it'll sterilize your water. But I have 3 canisters that go with that. So it's quite a big machine that lies inside your room. As well as that, the boxes and all the supplies. I'm after getting a supply today. And there's about 15, 16 big boxes that come every time. So it's a lot. You need to store it somewhere. They do give you a shelving unit that you can actually put all your stuff into, and it can store it, so it's much easier. You don't have to be rooting through boxes and things like that as well, so that's good. Some people might find, like I usually do dialysis on my own because my husband would be working, so I would be on my own, and some people might be a bit afraid of being on their own while doing it. At the beginning, I was more afraid of the machine than I would have been about the medical side of things. But you're so used to it then, it doesn't matter. It doesn't really bother you anymore. Some people might be just finding it a bit lonely, whereas I actually like the loneliness and being on my own. I think that's really it. I am delighted I picked home dialysis, and I'm delighted Prof. Conlon told me to go a few times and get it done. I did try to do peritoneal, but it didn't work for me. So that would have been easier for holidays and that. But I'm quite happy now with I would be happy with a transplant, but at the moment I'm happy with home dialysis. So thanks very much, guys, for listening.
That's great. Thanks, Michelle. And it just gives you a flavour, of natural patients' experience of it. So thanks for that, Michelle. And we'll be coming back with questions before we finish. So next, I'm going to move on to Mary Stewart. So Mary, if you'd like to unmute yourself, and if you could tell us in 5 minutes about your experiences. Mary, you seem to be having some trouble there. Oh,
yeah.
Lovely.
Thank you, Carol. Thank you. And thanks, Michelle. I made a few notes so that I wouldn't go off track or talk for too long. So I'll just begin by introducing myself. My name is Mary Stewart. I'm 72 years old. I'm married to John. I have 4 sons and I have 7 grandchildren from a previous marriage. And my background is I work as a counsellor. And I've been on one form of dialysis or another for 2.5 years now. In September 2018, about this time 3 years ago, out of the blue, I got very sick and I was diagnosed with end-stage kidney failure. It was very shocking for me, as I thought I was enjoying a good level of health, and I'd never even had a kidney infection in my life. The doctors discovered I had vasculitis, which is an inflammation of the small blood vessels. And in my case, it attacked my kidneys. They told me they don't know if vasculitis is hereditary or environmental, which is why they're doing a huge study at the moment to find out the possible origins of it. Initially, it was suggested they fit a Tenchcoff catheter in my stomach in case I needed urgent dialysis. When they tested the Tenchcoff, I ran into problems and they discovered I had several hernias. So I ended up on emergency hemodialysis instead. And I was on that for 8 to 10 months until the hernias were repaired and I healed. In August 2019, I started on peritoneal dialysis. So I was doing a combination of both hemodialysis and peritoneal dialysis for a while. I would say during my initial training on peritoneal dialysis, I was completely overwhelmed by the amount of things I had to learn. However, the training and the support of the renal team in Tallaght Hospital was excellent. I was still nervous and I thought it seemed to be taking me a long time to get all the steps right, until I finally decided that I'd pretend that I was learning to do something for someone I loved instead of for myself. And that actually worked like magic. It got rid of all the nervousness. So that was a great mental attitude to take and it worked for me. So now I could do home dialysis. And in October 2019, I finished up on hemodialysis, and there were no more days in the hospital, and I was thrilled. I do my exchanges 4 times a day, 7 days a week, each exchange taking me about an hour and a quarter from start to finish. I was offered the opportunity in November 2019 to go on the nighttime machine. So this meant me linking up to the machine for 8 to 9 hours a night, leaving me free during the day, which sounded enticing. I had more great training from the renal nurses on this, and I was quite confident on the home dialysis machine. This option gave me free days, and it felt liberating initially. Unfortunately, a sad story, my sister was diagnosed with cancer just after my kidney disease diagnosis. She finally became quite ill, and I wanted to move in and live with her while she was dying. And I needed to be free to go to her aid, so I reverted back to the daily exchanges instead for a while. After my sister died in April 2020, I went back to the nighttime machine. Unfortunately, I began to find it difficult to sleep with the noise of the machine. Mind you, it could have been my nervous system and nothing to do with the machine at all. COVID was now in full flight, so unable to go out with the restrictions, I reverted back to the 4 times a day regime, and I'm still on that now. I've been on the daily exchanges for almost a year. I find it easy to manage now, and I have relaxed into the routine. I'm able to do it around my family and my work life. And with the restrictions now lifted, I can visit my family and friends, and I bring my supplies with me. My family, my grandchildren, my friends are used to seeing me do my exchange now. And this year we even managed to have a lovely holiday in the country, thanks to the Irish Kidney Association, who had all my fluids delivered. On a couple of occasions, I've had to do my exchanges in the car, and I've managed to do that without any difficulty once I'm armed with my sterile towels and my hand sanitizer. At the moment, I'm enjoying this way of managing my kidney disease. I like the flexibility and independence it offers me. I like being able to do it in the comfort and privacy of my own home. The only disadvantage, I suppose, is the time it takes out of my day. But I use the time fruitfully to read and meditate and listen to music or a podcast, or to chat to someone or catch up on my favourite TV. Thankfully, I've managed to get into the kidney transplant pool, and I'm very hopeful of getting a kidney. Initially, I felt I was too old to be accepting a kidney out of the pool. And then I was told that if they get a kidney from an older donor, it would be suitable for me, where it would not be suitable for somebody young. So, fingers crossed. I wish you all the very best with your dialysis decision. I'm sure you will make the right choice to yourself. And with the advice and support from your doctors, your renal team, and the fantastic Irish Kidney Association. My challenges help me realise all the options I have. And I always feel reassured and grateful that there are so many options available for the management of kidney disease. And also knowing it's possible to change treatment if the one you're on doesn't suit you, just like the professor said. So it's good to keep that in mind. Thank you very much. I'm delighted with the opportunity to share my story with you.
Thanks so much, Mary, and I'd like to express my deepest condolences on behalf of everybody here on the death of your sister. That was a very moving and emotional story you told us, and it just shows you the capacity people have to deal with issues. And I could see the prof shaking his head as he heard about you doing dialysis in the car. Not something we recommend, but it shows you you know, and it's something since I've come to the IKA that is really inspiring, the resilience that kidney patients have. You know, I just find it brilliant to work with people who, you know, are just so strong, going through so much, like, you know, and everybody has their own story, and yet they deal with so much. So well done. Thanks, Mary.
Thank you, Carol.
So last but not least, we're going to talk to Michael Stapleton, who's going to talk about APD. So Michael, over to you now.
Hi everyone. My name is Michael Stapleton, and I'm automated PD, like Carol said. So I'm 38 years of age, and I've been on this for almost 2 years now, so since 2019. I think I chose this at the time because I was relatively young and relatively fit, and Professor Conlon in Beaumont kind of recommended that this would be the most suitable dialysis for me, and I took his advice on that. So as the others mentioned, there's really excellent training around it. First of all, I got the 10-cuff catheter inserted in November 19. The thought of I'd never had an operation before, or an abdomen operation. The thought of it was much worse than the actual operation itself. It was 40 minutes and I was recovered, and I was actually playing golf 3 or 4 days later, which I probably shouldn't have been, but I felt like I was fine, ready to go. So I started the dialysis in December. Someone came out to my house, one of the nurses from Beaumont, and she walked me through how to set up the machine. It's not very complicated. There's kind of a lot of wires and stuff, but they give you a really simple to follow kind of set of steps to set it up. And I guess the first time I did it, especially on my own, was quite daunting. Afraid not to make any mistakes. Then I was looking at the instructions in the Baxter book, but within a few days I had it down, and it's basically I could do it in my sleep right now. Although you have to be careful not to touch certain things, and it has to be hygienic. It's really important. So I'm glad I chose that option. It's given me a lot of independence. I do it every night for 8 hours. The machine is in our bedroom. It has a pump in it which runs constantly for the full 8 hours, and there's ups and downs and everything, and it took us a bit of time to get used to it, but we both sleep very well now. It's kind of like background noise, like it's raining outside or something like that. We're just used to it. In terms of the amount of equipment, the amount of boxes that are delivered, so that I get a delivery once a month from Baxter. I get a text on, say, the Friday before delivery, and they ask me what I have left, and I just tell them. I make a phone call. I tell them what I have left, and they know exactly what my regimen is, and they order the necessary amount of boxes, and they arrive the following Friday. And I store it in my hallway, and there is quite a big storage requirement for the boxes for peritoneal dialysis. I'm on, it's about 50 boxes a month for me, and I just stack them in my hall. My hallway is quite wide, and I just leave them there, and I bring them one up a night as I need it, instead of carrying them all upstairs in one big go, which would be a big job. But it's quite manageable. The boxes themselves, they're not too heavy, maybe 4 or 5 kilos, and they're easy to lug around. The machine now is a different story. Like the machine, and I know Professor said it's easy to travel with it, but the machine and the box together are about 26, 27 kilos. And Ryanair were like, they thought I was mad traveling with it a couple of years ago when I went skiing, but which I was able to do for free. And I suppose the caveat there is you have to let them know in advance that you're going to be traveling and that you're going to bring a medical device. But when I did that, it was all fine, no problem, everything was free, and it worked out really well. The box the machine travels in is basically a big plastic. It's basically a bulletproof box. It's hard to describe how indestructible it looks, but it keeps the machine safe, and it's actually easy enough to wheel around. Just lifting it is the tricky bit. So I've traveled several times with it. Just to give you an idea, I went skiing in February last year, right before, about a week or two before everything shut down in Austria for COVID. I rang about 4 weeks in advance, and Baxter delivered all my supplies to a hotel in Austria, and they refused to take it because they saw medical stuff on it. So it got sent back, and then I had to ring them and get it sent back the next day, which was a little bit of a pain, but it worked out, and it was already there when I arrived. And I had to just go through the normal procedure every night, and I had to dispose of the cardboard and the plastic, which it is what it is. It was not too bad. And I've done several trips around Ireland where I load up the car with the machine and left several boxes for 2 or 3 nights, and it's no problem really. So it's quite portable from that perspective. It's real advantage of this. I got this type of dialysis. In terms of disadvantages, I suppose the storage is a big thing in the house, and the waste. cardboard and plastic waste is phenomenal. So you have to get rid of that. Like, it's not going to fit in your green bin. I do a trip to the local recycler every 2 weeks to get rid of it, and I fill my car every 2 weeks with that much cardboard and plastic. I think because it's a really small price to pay for what is a pretty good quality of life. I suppose one of the other advantages is that I do dialysis 7 to 8 nights a week. I find that my general health is extremely good. I play loads of golf. I'm really active. My energy levels are probably 50-60% of what they would have been before. So I'm not saying I can't run a marathon. I'll be exhausted, but I live a fairly good quality of life, and I look after myself, and I follow the dietary plan, which is not too bad as well on PD. So I suppose in terms of pain and stuff as well, it's I was talking to someone recently who's getting a bit of drain pain, and he's only on dialysis a few weeks. That went away for me pretty quickly, and so did any kind of, what was it, any pain in the legs. I used to get that from I suppose, I don't know what it was actually, but like a cramp in my calves and stuff. After a few months on PD, that just stopped happening. I think my body found a level it was comfortable with. So I've been, I'd say, pretty healthy for the last 2 years, as best I can be on PD. If I was to do anything differently if I was starting again, I don't think I would. I think I'd still choose PD. It's, again, like I said, it's given me the flexibility to do what I want. I can manage around it. When I tell people I'm on dialysis, they are always shocked. They never really, like, I don't look tired. I don't really carry water. Although once or twice I have got overloaded a little bit, but that's probably my own fault for drinking too much. And then that levels off over time. If I have any tips for people considering this option, I'd say it's a very good option if you want to be active during the day. It works at night, and if you can put up with the sound of the machine pumping away in the background, I think it's an extremely good option. The storage is a big consideration, but like it allows you a huge amount of flexibility and still the ability to travel. I'd say relatively easy within Ireland, and with a little bit more effort internationally. So it's a really good option.
Great, thanks, Michael. I think you're a poster child for home dialysis, a real champion of it. The way you described it was amazing, going skiing.
Yeah, and I was only on it 3 months at that stage. Maybe I was a little bit naive, but we did it. We made it work.
Yeah.
It was a bit of effort. It wasn't seamless by any means, but I think it was worth it.
Yeah, yeah. And as you know, we in the IKA believe holidays are such an essential part of helping people have a great quality of life. So thanks for showing that it is possible to even go skiing when you're on dialysis. So thanks for that. So we're going to ask you to use the chat function. If you can click on the chat function down at the bottom of your screen and type in any questions. And while you're doing that, I'm just going to ask the Prof, does he have any comments he wants to make on anything that's been said so far?
It's a good job I'm sitting down when I heard about somebody doing an exchange in a car. But it's not the strangest place I've heard of an exchange being done. One of my patients in the UK did one halfway up Mount Snowdonia, so it's not the strangest place. I think it's great to hear those stories. They show that the resilience, as you said, Carl, of our patients, how good they are and how much they will live as best they can with what they have. What struck me now, and again, as I said in my comments about Humpty Dumpty, some of the things I didn't see, for instance, having to go down to the recycling centre every 2 weeks with your waste is quite significant, and something I wasn't really personally aware it mounted to that much. And I'm glad, Michael, that you shared that with me, and it's something I will take forward, and I think it's something we need to talk about with the powers that be, because it is something that I feel strongly about, that the patients on home therapies are what you pay in taxes alone, if they gave you half that, it would cover your electricity costs, never mind the cost of dialysis, if they what they save in taxes alone. It is something I think we need to look at, and I'm going to see who I can get, or whose purse strings we can shake down to try and get some funding for that, because it is a significant barrier to home therapies.
Yeah, and that's actually one of the questions. I'm not sure that anybody can answer that. How much is the electricity with the nighttime dialysis? And there's only tax relief on those bills. You don't, if you're paying tax, obviously if you're not paying tax, it's no use. Can any of you, Michael or
I didn't even know that existed, so I need to find out about it.
oh, right,
Yeah.
yes, it is tax relief. Check this month's support magazine. You'll find how to go about claiming it in that, Michael.
Great.
What was the additional cost for you, Michael, on the nighttime dialysis?
It can't be too much now. My electricity bill for my entire house is about 75 or 80 quid a month. So it can't be more than 10 or 15 euro, I'd imagine, if even that.
Carl, it's mainly for the home for the home hemodialysis,
Right.
because the machine has to run the RO and has to run. They're not heavy, they're not huge. It's the water and the waste and the electricity, but it adds up in a year. And I know in other jurisdictions roughly how much they give each people to cover their costs. But they require a certain amount of the home PD. It's not an awful lot. The plate warmer is less than a kettle a day.
Yeah. And do we have any estimates on the hemodialysis, how much extra it would cost?
Michelle probably knows that better than I do.
Yeah.
I'm not really sure, but I know our bill did go up. It used to be like it's about 50 euros every bill or so more. I'm not really sure now, but I think it is. It's quite hard to judge. I suppose during the summer it was very easier to judge than the winter, because you wouldn't have the heat on during the summer as much.
Yeah.
But,
It's like running a washing machine, roughly speaking.
Is it? Yeah.
Yeah.
I presume if you do nocturnal, it would be a bit more, because the machine is running for 9.5 hours. I know it's a slower rate than that, but
okay. And then a question for you, Brock. Do both types of PD require the use of a machine?
The CPD has just got a small warming plate, which is tiny. Mary can talk to that, but it's about the size of a large book, and it's flat and it plugs in. It doesn't take an awful lot. The APD machine is bigger, and it does come with its bulletproof case, as Michael described it, and that's a bigger machine. But it's more the story of the bags and the plastic waste. There is quite a bit of plastic waste for both of them.
Yeah. So that's great to hear you say that you're going to look at the level of waste, because there's quite a few questions about that in the chat feature. And just for everybody, Colin has put in a very useful website link. If you click on chat, you'll see it for claiming the tax relief on the additional expenses that kidney patients incur, and it's also in the support magazine as well. And then another question is, for the home therapies, what type of water system do you need?
Usually they have tested from microbiological purity. The RO itself is very efficient at taking away all the toxic waste. It's the microbiology purity, and that there's no unusual contaminants. Now, we do work with Irish Water, and we've met them, not actually recently, but we used to meet them before, let's say BC, before COVID. We used to meet them to make sure there's certain chemicals we won't allow them to use or be careful about, called chloramines. But normally, for most water, it's quite good. The problem is sometimes in very rural areas is where do they get their water from. Some of the local water schemes are not quite as good as others, and it might just need extra filters. And so it's a problem for Baxter rather than the patient. They just have to put in extra filters and to ultra purify the water. Sometimes, as Michelle said, she has three. I think you have 3 filters. You said. Others get away with a lot less.
Yeah, 3. Yeah, I have the RO 3 filters, and there's a pump in the attic, which is very noisy. So we can't really do nocturnal. It would be just a little bit too noisy for us.
Yeah. The other thing. Sorry, Michelle. Go on.
When you go on the machine first, you have to check every day for chlorine. So you check the chlorine levels before you go on the machine. So it's just another safety feature.
Great. And then one other advantage is that when you're on home therapies, you can be added to the priority list with both Irish Water and Electric Ireland, and we'd strongly recommend you do that because it means they will notify you of any outages in advance. And then if there's any problems with your electrics or water, they'll prioritise reconnecting you. So that is actually one of the advantages. So if the entire area goes out, they'll actually reprioritise the people which, if it's an individual issue, they'll prioritise you rather than your next door neighbour. So that's one benefit of it. I'm conscious of time, and the Professor has been working very hard, as all you, and it's getting late, and I'd like to thank him. He put, as you can see, put a considerable amount of time and effort into preparing the presentation, and he has a full clinical practice as well as being head of the NRO. So thank you very much, Professor, for giving your valuable time to us. That's, I think, has been really, really informative, and I can see people are clapping. You can also show your reactions on the bottom of the screen as well. And I hope this will be the first of many times, hopefully, that we can get you along to talk to us, because certainly I found it very interesting indeed. So the next part of the session, and we'll still aim to finish up by 8:30, is about vaccinations. So Professor, you're very welcome to stay, but if you want to leave at this stage, that's fine as well. Colin White was at the Community Network meeting last week and got an update as what was happening. Some of you will have seen it on our social media, but just in case, we said Colin could go through the vaccinations update here as well.
Right, thank you, Carol. The vaccinations, you will hopefully have seen that starting Wednesday this week, people who are immune compromised, kidney patients, will start being contacted for appointments to get a third vaccine dose. Now, you will have heard some discussion possibly on the radio of the difference here, that for the immune compromised, this third vaccine dose is a top-up. It's not the booster shot. The booster shot they're talking about is for the over 80s in the community and the over 65s in a residential setting. So it's a top-up to try and bring the immune compromised up to or fairly close to kind of the same level of immunity as the general population. So it's kind of felt this is why this group is getting prioritized, is that it felt that the immunity developed to date just is probably insufficient. So we just need that extra boost. According to the briefing we got, the vaccinations will happen mostly in either the vaccine centres or your treating hospital. And as I say, they're supposed to start issuing appointments on Wednesday, and on Friday, theoretically, they'll start rolling out the vaccinations. So it's not as big a group as the group 4 and group 7 from the first round, because some of those people, like people with COPD, were just high priority because they were high risk. This is high priority because we need to support the immune system a little bit more. But at the same time, just because you don't necessarily get an appointment on Wednesday, don't panic. Like, there's a lot of people who need to be contacted, and they will be working their way through it. But for those of you who are part of local branches, if you can feed the word out that if people are finding that it is taking time for appointments to come through, do ask them to get in contact with myself. And if there is a kind of a real issue there, we have some good contacts that can help us resolve them. But they don't anticipate too many problems because, well, it's good to see from John Whelan. He's received his appointment for the top-up vaccine and the flu vaccination. So that's good news. They're ahead of the game. But yeah, we don't foresee there being any major problems because the vast majority, thankfully, of this group has been in the system for jab 1 and jab 2. So I don't know if the professor maybe wants to throw in any.
No, I haven't. No, and we got it extended to people with severe, not yet on dialysis, on the grounds. And I said, to be sure. The two main risk groups are obviously the dialysis patients and the transplant patients, but we got it extended to the people with mild, with moderate, with severe renal failure on the grounds that their immune. A lot of people have a very good immune response, but some won't, and it's very hard to predict who will and who won't. And it's a blanket. It's as you said, it's a top up. But can I give you a good news story from a clinical viewpoint? Whereas this time last year, if someone with severe renal failure got COVID, most of them did extremely badly, and we had unfortunately a few deaths. What we have seen this year, those that did get COVID seemed to survive. They got a flu, but they all survived. We've been doing very well post vaccination. So while it gives you a nasty flu, the vaccine does work and protects you against severe illness, even in the people with renal disease. And I don't want that message to get lost, that it does protect you against severe renal disease in 98% of people, even in renal patients. But we want to get that up even higher.
I think that's a very key message, because if we look at vaccines, there's the extraordinary case of smallpox, where the smallpox vaccine was able to help us eradicate smallpox entirely. But most other vaccines, it just kind of helps moderate the impact of the illness. It doesn't necessarily kind of stop it coming into your system. But certainly all the research I've been reading internationally has been positive in relation to our community. That's as Professor said, the impact, which has got to be a good thing.
Great. Okay, well, we're coming up to 8:30, so we just wanted to do a quick poll, and this is really just to take a snapshot. A few people have talked to us about itchy skin, so we're just going to launch a poll, and we want to find out, is this a specific issue for people on dialysis? Is it a big problem, or is it a little problem? So it's just it's a snapshot. It's nothing scientific objective, but just to see how much of an issue it is.
Carl, I'm going to leave. I think this doesn't apply to me.
Oh, okay. No, thank you very much.
Good luck all. Goodbye.
Thanks.
Thanks.
Thanks very much.
Bye-bye. Thank you.
Bye-bye.
Bye.
Bye.
Great, you can see people are completing that. And a significant amount of people are saying itchy skin is a problem for them so far.
I'm getting itches everywhere now, just people.
Yeah.
It's one of the problems, isn't it?
Scratch my head.
Yeah. Okay. Right. So I'm going to close that one down because it's just to get a quick snapshot. Is this an issue that we should be raising with people? And then the next one we wanted to do was just to get feedback, it's really important to us that the sessions we have with you are useful and that you're finding them beneficial. So what we try to do after each session is to actually just get some feedback. So I'm trying now to launch a new poll as to whether this meeting was helpful. And it's anonymous. So we're not going to be upset at individuals if they didn't find it anyway helpful. And if there are any comments you want to make, you can email them into myself or into Colin or just into info@ika.ie. So the results are coming in really high, that the vast majority of people are finding it helpful. And we have, oh, that was very quick. 22 out of 23 people found it helpful, and one person found it so much helpful. So that's great for us. Thank you very much for that. So that's it for tonight. I don't know whether Colin McKenzie, you want to say a few words of goodbye before we finish?
No, just to say, Carl, you're all very welcome, and we're delighted that you've tuned in, as it were, because we're anxious to spread the word and get people involved. And there's all the discussion we have and all the insights we have are not confined to us out in Donor House or at a board meeting. That we're very interested to hear how you're getting on, and because you are the Kidney Association, the members, and just if you know anybody else, any other members, please spread the word, and maybe the next time we'll have even more people at the gathering. So thank you very much, everybody. It's been a pleasure to hear you and hear the professor's lecture. Thanks very much.
Yeah, and thanks to you all for your time here, and particularly to our 3 patients who bravely, and it's not easy to even on Zoom come along and share your story, Michelle, Mary and Michael, and I think that it's really helpful just to hear from other patients, isn't it, and to see how everybody's journey and everybody's experience is so different, and I think we can all benefit just from hearing those stories. So again, thank you very much for taking the time out to prepare. It was obvious you had all put a bit of time and effort into putting together your stories, and you told it very well and very concisely. So thank you for that. So with that, we leave at that stage, and we'll have more events coming up. There's one being hosted by the European Kidney Patient Federation, and Colin is going to hopefully put the link for that into the chat when we can. He's going to screen share it. Great. This is not one hosted by us, it's hosted by the European Kidney Federation. Oh, he's doing a screen share, even better. You might want to put that into, he's just copying it across. So that's on the Tuesday, 28th of September at 4 p.m. And that's free, so people can register to join that. And then we have a session for branch officials only, on the Monday the 18th of October, so that's for branch officers, and then we'll be recording the service of remembrance and Thanksgiving on the 6th of October, and RTE will be broadcasting it, so we'll confirm that date when we've got it. Okay.
Yeah.
So we'll send you out copies of the slides and also the link of the video when it's ready. There'll be a bit of editing required to that. Is that okay?
Yeah.
Thank you.
Great.
Thank you.
Thanks very much, folks.
Take care, everybody.
Thank you, everybody.
Bye. Thank
Bye
you.
now.
Bye.
Thank you. Bye-bye.